Today I'll be explaining a non-imaging procedure known as the Schilling test. Robert Frederick Schilling was a professor and physicist known for his research on vitamin B12, which is also known as cobalamin. He derived a test for patients with a cobalamin deficiency to measure the amount of cobalamin that it has or has not been absorbed by the patient. The Schilling test is what he called it, therefore determined whether the cause of the cobalamin deficiency was due to pernicious anemia or other reasons such as malabsorption. Pernicious anemia is an autoimmune disease state caused by the lack of cobalamin absorption in the body. This is due to the absence of the intrinsic factor, which is produced by the parietal cells of the stomach. Before I carry on with the Schilling test, we need to understand what cobalamin is and the normal absorption process of cobalamin. Cobalamin is a nutrient that plays a role in erythropoiesis and myelin synthesis. Erythropoiesis is a process in which new erythrocytes are produced to replace the oldest ones. Cobalamin is of utter importance in this process for proliferation during their differentiation. A lack of cobalamin will result in impaired DNA synthesis, which causes erythroblast apoptosis, resulting in megaloblastic anemia. This presents as headaches, tachycardia, and fatigue. Cobalamin also plays a role in the regeneration of myelin, where cobalamin deficiency will result in demyelinating diseases of the brain and spinal cord. For these reasons, patients with cobalamin deficiency may have the following neurological and hematological manifestations: megaloblastic anemia, leukopenia, paresthesia, peripheral neuropathy, and also psychosis. But how does a deficiency of cobalamin occur? This vitamin can only be obtained from dietary sources, including animal and dairy products such as meat, eggs, and milk, or by supplementation. An understanding of the cobalamin absorption process helps illuminate the potential causes of deficiency. With the help of this diagram, I will explain the absorption process of cobalamin. There are three cobalamin binding proteins that facilitate its absorption in the body, namely transcobalamin 1 or the R protein, intrinsic factor, and transcobalamin 2. Cobalamin is ingested in the body through dietary sources, preferably animal proteins, where the proteins are bound to the cobalamin. Through the initial stages of digestion, the amylase enzyme from the salivary glands breaks the bond between the proteins and the cobalamin. The R protein, also secreted by the salivary glands, is used to protect the cobalamin from the gastric acid when it reaches the stomach. The R protein is also secreted by the gastric acid and the biliary system. In the stomach, the hydrochloric acid will convert the pepsinogen into pepsin, where the pepsin will also break the bond between the protein and the cobalamin. The R protein then binds to the free cobalamin to protect it from the gastric acid. The parietal cells in the stomach secretes the intrinsic factor, which is important for cobalamin absorption. As the bound R protein and cobalamin reaches the small intestine, the pancreas secretes the enzyme protease to break the bond between the R protein and the cobalamin. The cobalamin then binds to the intrinsic factor in the small intestine, where the absorption of the cobalamin will occur in the terminal ileum. The intrinsic factor is then degraded in the lysosome organelle, where it releases the cobalamin into the cytosol of the cell, which transports it into the bloodstream. Transcobalamin 2 will then bind to the cobalamin in the bloodstream, which will facilitate its uptake into the cells, or transcobalamin 2 will transport it into the liver to be stored for use. Now that we understand the absorption process, we can comprehend the Schilling test. The Schilling test concentrates on the assessment of the absorption of cobalamin and gives us an idea of what the cause of the cobalamin deficiency is. Indications for the Schilling test includes low cobalamin levels with or without neurological or hematological symptoms, to confirm the diagnosis of cobalamin malabsorption and determine the mechanism, hematologic changes with non-diagnostic serum tests, to detect patients at risk of cobalamin deficiency, and to determine if a patient of cobalamin treatment actually has an absorption defect. However, pernicious anemia is the most common cause for cobalamin deficiency. Therefore, it is the most important indication for the Schilling test. The protocol that was used for the Schilling test is as follows. The patient preparation. The patient is examined by the physician and then sent for blood tests to examine the cobalamin levels. The blood test will then show a deficiency of cobalamin in the bloodstream. The patient will then be booked for the Schilling test. If the patient has had a previous radiopharmaceutical examination, then the Schilling test must be booked 1 to 6 weeks after the administration of the radiopharmaceutical, depending on the type of kit used. This is because radiopharmaceuticals are eliminated through the urine, which will have an effect on the Schilling test results. Cobalamin therapy must also be withheld for at least 48 hours prior to the Schilling test. The patient should have nothing to eat or drink from midnight before the examination. When the patient arrives at the department in the morning, he or she should empty the bladder, and the procedure should then be explained to the patient. The equipment needed. Empty urine holders of 500 ml are given to the patients to collect their 24-hour urine samples. A kit from the radiopharmaceutical manufacturer is provided to the nuclear medicine department to draw up the urine samples and then sent back to them where they measure the urine samples in a well counter or a well counter with 2 sodium iodide doped with thallium crystals. The radiopharmaceutical first used was cobalt-60, which has a half-life of 5.27 years and gamma energies of 1.17 MeV and 1.33 MeV. But then they discovered that cobalt-57 and cobalt-58 are more suitable labels for the Schilling test due to their lower half-lives and energy. Cobalt-57 has a half-life of 271 days and decays by electron capture, which emits gamma rays with energies of 122 keV and 136 keV. Cobalt-58 is used in the Dual-Isotope Shilling test, and it has a half-life of 72 days and decays by electron capture, which emits positrons with energy of 0.48 MeV and gamma rays with energy of 0.81 MeV. Cobalamin is labeled with 0.5 microcuries of cobalt-57 in the form of a capsule. The procedure to be followed differs depending on the institution performing the examination. Therefore, I will explain the most common procedure that was used. The patient can be booked in the ward or come as an outpatient. There are 4 stages to the Schilling test. On day 1, stage 1 starts. The patient is given the 0.5 microcuries cobalt-57 cobalamin capsule to drink with 100 milliliters of water. A subcutaneous injection of carbachol of 0.25 milligrams can be given to the patient to correct for the fact that the patient doesn't have pernicious anemia but may show a false positive defective absorption. The carbachol would not have an effect on the absorption of cobalamin. After 2 hours of no food and drink, the patient will receive an intramuscular injection of 1,000 micrograms of non-radioactive cobalamin, which will be absorbed faster than the oral dose. The intramuscular cobalamin saturates all of the transcobalamin 2 receptors, so that all of the receptors are used. Therefore, the oral radioactive cobalamin can't bind to the transcobalamin 2 in the bloodstream, but will go to the kidneys to be filtered out into the urine instead. Cobalamin will also be excreted through the feces. We wait 2 hours for the oral cobalamin to be absorbed as much as possible. 2 hours after the non-radioactive cobalamin is injected, the patient may have a light breakfast. The patient then goes home or to the ward with the 500 milliliter urine holders to collect his or her urine after 24 hours. On day 2 in the morning, the patient comes with his or her full urine holder for the department to test. The patient is then given a second intramuscular injection of non-radioactive cobalamin. This is a flushing dose that will remove or flush out any residual radioactivity that can be mobilized, and also to prepare the patient for the second test if the first test was abnormal. The urine sample is sent to the radiopharmacy to be tested, and if the results are abnormal, then the patient has to come back on day 4. On day 3, stage 2 starts, where the patient has to fast from midnight for the second test the next day. On day 4 in the morning again, the same oral dose of cobalt-57 cobalamin is administered to the patient, as well as a capsule of intrinsic factor administered at the same time. 2 hours later, an intramuscular injection of 1,000 micrograms non-radioactive cobalamin is administered. The patient may have a light breakfast after 2 hours. This step determines whether lack of intrinsic factor is the cause for the cobalamin deficiency. On day 5, the patient returns the full 24-hour urine sample to be tested. The urine sample is sent to the radiopharmacy to be tested. If the results are abnormal, then stage 3 will commence. On day 6, stage 3 starts, where the patient will start a 2-week prescription of antibiotics. The step is done to confirm whether bacterial overgrowth is the cause for the cobalamin deficiency. On the last day that the patient has to take the antibiotics, the patient is given the radioactive oral dose of cobalamin, as well as the intramuscular non-radioactive cobalamin 2 hours later. On day 15, the patient brings the urine sample back to the department to be tested. If the results are still abnormal, then stage 4 will commence. The last stage starts on day 16. The patient will be given pancreatic enzymes for 3 days. On the 3rd day, the course will be followed by the intake of the radioactive oral cobalamin. 2 hours later, non-radioactive cobalamin is administered intramuscularly. Patient comes back 24 hours later with the urine sample to be tested. This stage confirms whether pancreas dysfunction or pancreatitis is responsible for the lack of cobalamin. The urine samples are calculated in the radiopharmacy as follows. The cobalt-57 cobalamin capsule and a 4 ml standard solution is counted in the well counter for 1 minute. The capsule standard ratio is calculated as follows. The capsule standard ratio is equal to the capsule count per minute divided by the standard count per minute multiplied by 100. The standard solution contains the equivalent of 1% of the total radioactivity in the oral dose. The urine sample is mixed thoroughly and 2 4 ml aliquots are pipetted into counting vials. The urine sample, reference standard, and 4 ml of water as background is counted for 20 minutes using the cobalt-57 window. The percent of urine excretion of labeled cobalamin is calculated as follows. The percent of urine excretion is equal to the average counts of urine minus the background counts multiplied by the total urine volume divided by 4 multiplied by 100, which is then divided by the capsule standard ratio multiplied by the standard counts minus background times 100. The interpretation of the results from the 4 stages are as follows. In stage 1, if the urine excretion percentage is more than 10%, then the patient is normal without cobalamin deficiency. If the results are equal to 10%, then the patient has a dietary problem where they need to ingest more animal products or cobalamin supplements. If the results are less than 10%, then there is an absorption problem. In stage 2, if the results are equal to or more than 10%, then we have corrected the problem with the administration of the intrinsic factor. This means that the patient has pernicious anemia due to a problem with producing the intrinsic factor. If the results are less than 10%, then stage 3 commences due to the problem not being corrected. With stage 3, if the results are equal to or more than 10%, then the antibiotics corrected the deficiency, meaning that the patient has bacterial overgrowth. If the results is less than 10%, then stage 4 commences. In stage 4, If the cobalamin levels normalizes, meaning it's more than 10%, then the pancreatic enzymes have corrected the cobalamin deficiency, meaning that the patient has chronic pancreatitis. The Schilling test stops at stage 4, even if the results are lower than 10%. False positive and false negative results can occur in any stage. The Schilling test may have false positive results due to incomplete urine collection, where loss of a urine sample may result in falsely low cobalamin excretion. Renal obstruction or failure causing diminished glomerular filtration, which in turn causes a slower excretion of cobalamin in the urine. Chronic cobalamin deficiency, which causes atrophy of the ileal mucosa. This results in a decrease of intestinal absorptive ability. A large radioactive dose of cobalamin causes a decrease in intestinal absorption, causing a false positive result. The Schilling test may have false negative results due to old age, where a patient has gastric atrophy. Acid blockers in iron anemia leads to low gastric pH. Alcohol and folate deficiency. A previous radiopharmaceutical examination performed with no waiting time between examinations, and fecal contamination due to diarrhea in female patients. A modification of the Schilling test procedure was conceived in 1963 called the Dual-Isotope Shilling test. This was conceived to improve convenience by making the test shorter and also more reliable. This modification procedure performed both stage 1 and 2 of the Schilling test at the same time using cobalt-57 and cobalt-58. The procedure is performed as follows. The patient preparation is the same as the normal Schilling test. A kit is provided to the nuclear departments for the manufacturer for use containing the radiopharmaceuticals. For reference purposes, the Schilling kit contains 2% of the respective administered doses per milliliter of matched cobalt-57 and cobalt-58 standards. 1 capsule of 0.8 microcuries cobalt-58 cobalamin without the intrinsic factor, and 1 capsule of 0.5 microcuries cobalt-57 cobalamin pre-incubated with the intrinsic factor is administered to the patient. 2 hours after oral administration, an intramuscular injection of 1,000 micrograms non-radioactive cobalamin is given to the patient. After 24 hours, urine samples is collected where urine volumes and specific gravities are noted. The urine sample is then measured separately due to the different energies of cobalt-57 and cobalt-58. 3 values are determined, which include excretion of cobalt-57 labeled with cobalamin with the intrinsic factor, excretion of cobalt-58 cobalamin, and the ratio of cobalt-57 cobalamin with intrinsic factor to cobalt-58 cobalamin. The interpretation of the results are as follows. The normal percentage range of free cobalamin is 10 to 40%, the pernicious anemia range is 0 to 7%, and the malabsorption range is less than 6%. The normal percentage range of bound cobalamin is 10 to 42%, pernicious anemia range of 6 to 12%, and malabsorption of less than 6%. The normal range of the ratio of bound to free cobalamin is 0.7 to 1.3%, pernicious anemia range is less than 1.7%, and malabsorption range is 0.7 to 1.3%. I'll conclude with the following. The Schilling test has not been used for many years due to the various limitations. These limitations include the test is expensive, where treatments of cobalamin can be started after blood tests show cobalamin deficiency, and the treatment is also self-administered and inexpensive. The radiopharmaceutical kit can also be very difficult to produce, or it is not readily available. It is time-consuming with all the different stages. There are many causes for false positive and false negative results to occur. The test is dependent on normal renal function. And lastly, the kit provided was discontinued because there was concerns of potential transmission of mad cow disease via the animal-derived intrinsic factor. However, there is no other test available to determine the absorption of cobalamin to this day. I think it could still provide useful information and rational treatment decisions can be made when we know what caused the deficiency of cobalamin. The kits and radiopharmaceutical can be improved to provide less exposure to the patient and prevalence of mad cow disease. These next slides show the references that are used in this presentation.